Hi, my name is Marcy Kerpeck, and welcome to my presentation on lower limb amputation. I chose this topic because there may be an opportunity for me to someday work with people that have had lower limb amputations, and I thought it would be an interesting topic to research to find out more information about should I have this opportunity once I'm done with my studies here at West Chester University. So that said, my case study is a 32-year-old male who has had a bilateral amputation, more specifically a transtibial bilateral amputation. He has no specific health risks or concerns such as cardiovascular disease or diabetes. However, he is taking a beta blocker for his phantom limb pain. So what I would like to do is talk a little bit about the different types of amputation and some of the concerns when it comes to writing an exercise prescription for this person. And also I'm going to talk a bit about some of the terminology that is associated with amputation. That said, let's start with defining amputation. How do we define lower limb amputation? Well, first we have the word amputation, which we all know from many years of studying, that amputation is the removal of any body part, be it an arm or a leg, intentional, non-intentional. We all knew that one, but basically I thought it was important to kind of talk about the lower limb part of this term. If you guys are like me, when I thought of lower limb amputation, immediately I thought like entire leg or at least from the knee down. But interestingly enough, lower limb amputation includes not only the whole leg or part of the leg, but also can include the foot, part of the foot, or something as small as your big toe. So lower limb amputation includes all of the leg, any part of the leg, not just an entire leg or half of it. So I thought it was important to point that out for those of us that were not aware of that. So that said, amputations are also categorized by anatomical location, which I think is interesting to point out, simply because it's important to know that when you are doing your exercise prescription. The first type of amputation is known as Symes, and that is an amputation of the forefoot or midfoot, usually leaving the heel bone intact. You also have the transtibial, across the tibia, which is below the knee. You have your transfemoral, which is, across the femur, above the knee, and then you also have your hip disarticulation, which is the removal of the leg at the femoral hip joint. A couple of other terms I think are interesting and worth noting at this point would be unilateral, uni meaning one, which involves just one limb, and also bilateral, which is involving two limbs. So you're going to hear me refer to the unilateral, bilateral quite a bit throughout this presentation. And for those of you that are visual learners, I've included a few pictures here that I thought were very crystal clear as to where some of these amputations take place. You've got your transfemoral, transtibial, through the knee, hip disarticulation on the left. On the right-hand side, you can see that there's different regions that are described in this picture: above the knee, below the knee, and also that includes the toe amputation, the midfoot, and the Syme amputation down there at the bottom in green and pink colors. Okay, so not only are amputations categorized by anatomical location, they also are categorized by causes, because there are many different reasons, or many different causes for lower leg amputation. The first one is known as congenital limb deficiency, which isn't necessarily an amputation per se, but a congenital limb deficiency is would be someone that was born with all or part of a limb missing. It occurs at birth, so it's not something that occurs afterward. It's not intentional. It's not accidental. It's just something that you are born with. Acquired amputation is something that is caused by a disease. It could be a diabetic amputation, dysvascular amputation, and also vascular amputation. So those acquired amputations are caused by diseases. And the third one is the traumatic amputation, which is caused by some sort of traumatic injury or accident out in the field that takes place at the time of injury. I'd like to take a few minutes at this point to talk about the different causes of acquired amputation. As I stated earlier, they're obviously caused by certain types of diseases, the first one being vascular diseases. Also, most importantly would be the peripheral artery disease, which is the most common type of disease that would cause a sort of acquired amputation. You also have diabetes mellitus, another really common cause of amputation. In fact, when it comes to diabetes, as you know, there are some cardiovascular peripheral artery disease problems, and a lot of those issues may occur in the foot. So you may end up with a diabetic foot infection, and if that is left untreated and can't be controlled or taken care of, then you may have to have your foot amputated. And then also there are various infections that also may cause acquired amputations, and if they're left untreated, and the list, is a mile. It's a mile long. So rather than specifically state those different diseases or infections, I'd like to share this table with you. I thought it was a very helpful, very thorough table that describes some of the conditions that contribute to lower limb amputation. Of course, I'm not going to go over all of them on this table. As I said, it's kind of overwhelming. But if you look about a quarter of the way down, it does describe diabetes mellitus, be it type 1 or type 2. About halfway down, you can see that there are also the problems with peripheral circulation, arteriosclerosis, aortic aneurysms. If you go a little further down, you can see that, on that list, or go further across with the peripheral circulation, they mention gangrene, which is very common. And then at the very bottom of this table, you can see that it also lists trauma and some of the causes of traumatic amputations. So if you get a chance and want to take a look at that table, on your at your leisure, on your own, feel free to do so. At this point, I think it's important to talk a little about the psychological and emotional factors that go along with lower leg amputation. Don't get me wrong, other diseases I know, like cancer, diabetes, and cardiovascular diseases also, can be very stressful and, can be very emotional and very difficult to deal with, just like a lower leg amputation. But I thought it was important to bring this into my presentation for a couple of reasons, and I'll explain that as I get through the screen. So let's look at the planned intentional amputation. Those amputees, those people may experience the classic stages of grief. We all have heard about, like the denial, the anger, the bargaining, the depression, and eventually acceptance. That's not something you've probably haven't heard of before. As well as the classic stages of grief, a planned intentional amputee may experience anxiety that alternates with depression. They get very anxious, then they get depressed. They get very anxious, they get depressed. So that's kind of a common, it's a common occurrence with those people that have had a planned intentional amputation. Looking at the traumatic side, post-traumatic stress system often occurs with those people that have had traumatic amputation. They may have higher rates of anxiety and depression. Obviously, they did not plan to have this limb removed or whatnot. So therefore, their rates of anxiety and depression can be higher than those with planned and intentional amputations. And interestingly enough, there's a condition known as the phantom limb pain that I thought was important to discuss in this presentation because of some of the treatments that they use for phantom limb pain. That said, looking at phantom limb pain, what is it? It's pretty much what it sounds like. It's pain that an amputee may feel in that missing limb. Whether it be his entire leg, or maybe it's just his lower leg, and he feels this pain in his calf. For whatever reason, there's a lot of debate as to what causes this, and there's nothing that has been specifically determined for the cause of this particular condition. But interestingly enough, 55 to 85% experience phantom limb pain if they've had some sort of amputation. The pain may be like a tingling, a warmth, a cold, a cramping, and or a constriction of the missing portion of the limb. And the types of treatments may include pharmacological treatments, supportive non-pharmacological, non-invasive treatments, or invasive treatments. And since this presentation is not necessarily to focus on the phantom limb pain, I just wanted to point out the pharmacological treatments because some of those include medications that may affect the prescription that you would have for their exercise prescription, one of them being the beta blocker that I discussed earlier. So we're finally at the exercise prescription. Some general comments that I think are important. to discuss with all of you. Number one, non-vascular amputation. They elicit exercise responses similar to those persons without an amputation. The only difference is they may be, without one leg or two legs or part of a leg. So therefore, the only thing you need to consider really is the mode of exercise. And conversely, those people that have cardiovascular disease or some kind of vascular disease, you need to consider those diseases when writing their exercise prescription. As I stated, the modes of exercises may include and will be somewhat different, and you may use a one-leg bicycle ergometer, combined arm-leg ergometer, rowing machines, upper body ergometry, or combinations of any of those. Bilateral above-the-knee amputees are limited to arm ergometers or swimming, but also I did read that there are some situations where, depending on how much of the leg has been removed, you may be able to use a treadmill, or some sort of an exercise bike, but that would just depend on the person with whom you're working. And the last thing to point out here is energy expenditure for lower extremity amputees is much higher and directly related to the level of amputation. So if you're a bilateral amputee at the hips, then your energy expenditure is going to be much higher than if you had both of your legs, and vice versa. If you are perhaps just missing your foot or part of your foot, then your energy expenditure will still be higher, but not nearly as high as if you had more of your legs missing. So specifically, your exercise prescription will include, and this is going to look pretty familiar to all of us, for cardiovascular training, frequency 4 to 7 days a week. Your intensity, 40 to 80% of your heart rate reserve, or your RP of 11 to 16. The time, 30 to 60 minutes, beginning with 10 to 20 and gradually increasing. It's important to note that, because if you're working with someone that is a recent amputee, their level of fitness and, like I said, their energy expenditure is going to change, and so you need to gradually start them with their cardiovascular training with short bouts of 10 to 20 and then gradually increase. And then, of course, the type is going to be your arm ergometer, swimming, and like I mentioned on the previous screen, you could do some rowing exercises and whatnot. So again, really what's different is going to be the type of exercise. Moving over to strength training, your frequency, 2 to 3 days a week. Your intensity, 60 to 80% of your 1 RM, or a weight that would allow at least 8 reps. The time, I included the reps under the time, because that's the time that you take to do the reps would be 8 to 12 reps. And the type would be 2 upper body, at least 1 core, and 2 lower body if possible. I mean, keep in mind, even though someone is missing perhaps one of their legs, they could still do, one-legged squats. They could do one-legged glute bridges. They could do one-legged Romanian deadlifts. You just have to be a little creative, and you're going to have to also consider, balance exercises, because that's going to change things up if they're doing them with just one leg. Exercise prescription here continued would be some special considerations for strength training for those people that are on beta blockers, as I mentioned in my earlier slide in this presentation. They should be limited to light weights with high repetitions. They should use machines. If possible, they're preferred over the use of free weights. And also, you want to avoid heavy resistance exercises that elicit the Valsalva maneuver response, because that was not a wise thing to do for someone that's on a beta blocker, because that Valsalva maneuver and lifting heavy weights is going to increase the pressure in the blood vessels, and it's going to make it could be dangerous for someone that is on a beta blocker. So you want to be really careful when you're prescribing your exercise prescription for strength training. And here on the last slide, I'm sharing with you some pictures of the USA Hockey Sled program that they have, and I'm not going to go ahead and show the clip here that I have from YouTube, but feel free if you'd like to watch it. It's about a minute long, and it's fantastic. It's a fantastic program for people that have experienced lower leg amputations. It's something they can do after they've had this traumatic occurrence in their lifetime. So take a look at that when you get a chance. And again, I hope that you enjoyed my presentation tonight on lower leg amputation. Thank you.